like to ask the person, yeah. So can we start the session? Yeah. So I would like to, the first presenter, the Shalini Kumari, she is presenting on red flags on manual SICS with premature entry.
We want to discuss red flags in a case of SICS with premature entry. Improper bridal suture superrectus is the first key. After doing routine steps of conjunctival peritomy and scleral cautery, we proceeded ahead. First one is this frown incision is quite close to limbus, less than 1.5 to 2 mm. There should not be pooling of fluid at any stage. Over here you can see that the plane of groove and the plane of dissection with the crescent is different. That's why we are struggling with the construction of sclerocorneal tunnel. Again, entry of keratome into AC appears to be quite smooth, signaling a premature entry. During hydrodissection itself, because of the increased intraocular pressure, iris has started prolapsing into tunnel. Again, during prolapse of nucleus into AC, we use viscoelastic in ample amount. That also leads to increased intraocular pressure, and in this case, because of the premature entry, iris is prolapsing inward. Keeping the iris in its place is becoming difficult. In first attempt, nucleus delivery was aborted due to prolapsed iris in tunnel. Again, nucleus delivery was attempted, which was difficult due to improper engagement of nucleus into tunnel, entangling of prolapsed iris into tunnel, and imbalance of pressure and counter pressure force. Repeated prolapse of iris is leading to trauma, and it's becoming difficult to push it back into anterior chamber. While doing intraocular lens implantation, the maneuver is again causing iris trauma, though it was done very gently. We can see any amount of injection of viscoelastic.
So at the end, because of the repeated iris prolapse, it was tough to put the iris back into AC, and so abscission of prolapsed iris was done, and ultimately suturing of tunnel with 10-0 nylon filaments were done, and routine steps were followed. The first point is it was a case of high myope. So while giving a scleral route with the 15 number plate, the depth was more, and at that time only the whole thing of premature entry started and subsequent complications happened.
Afterward,
Okay, nice presentation.
routine steps were done.
Any immediate post-op complication have you got?
settled down. The vision was 12 parts with final suture, and it was
Okay.
stable.
Any form of astigmatism you got? You got some more astigmatism while taking the suture or somewhere?
Yeah.
Some cylindrical power was added after that?
After 6 weeks, we give the final glasses number. In this case, after 2 months, so there was cylindrical number, but
Okay.
I don't remember exactly
Okay.
how much it was.
Okay, 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 fine. Thank you. Thank you. So I would like to ask the next presenter, Mr. Anand Vardhan Malhotra, who will be presenting on lenticle extracting hydrocannula for smile refractive surgery. Is he here? Dr. Pratik Tiwari, he's here. Dr. Pratik Tiwari is here, the next presenter on Tenon patch. Dr. Satya Harish Reddy, you are Dr. Anand, right?
No.
Your name, sir?
Dr. Satya Harish.
Okay, okay, fine. So he will be presenting on cracking the heart, a simple meticulous approach.
Hello everyone. This video demonstrates pearls and strategies of phacoemulsification in heart cataract. We face immense challenges in management of heart cataract like incisional burns in view of prolonged phaco time, poor red reflex impeding capsular access, capsular lenticular block during hydrodissection causing posterior capsular rupture, leathery posterior plate which is difficult to separate, corneal endothelial cell loss, and often these cataracts are associated with thin capsule and weak zonules. Managing heart cataract starts with good pre-op evaluation to look for phacodonosis, pseudoexfoliation, and dilated pupil diameter. Unless extremely confident, peribulbar anesthesia is preferred, considering the prolonged duration of surgery. This is a brown cataract of a 74 years female with good pupil dilatation and no other comorbidities. Side ports are made 180 degrees apart using 20 gauge MVR, and 2.8 mm clear corneal incision is made with the keratome. Trypan blue staining of the anterior capsule not only helps to perform adequate sized rexes, but the capsular edges are well visible during chopping, thus avoiding tears. Dispersive viscoelastic that coats the endothelium and relatively more retentive is used to protect the corneal endothelium. It's important to make a 5.5 mm well-centered capsular rexis, as large rexis reduces the stress on the zonules, and small and extended rexis are more prone for posterior capsular rupture. During hydrodissection, use limited amount of fluid and always tap the center of the elevated nucleus to avoid capsulolentricular block causing posterior capsular rupture. Ensure complete hydrodissection by rotating the nucleus using a Sinskey hook. Lack of epinucleus, thin capsule and weak zonules makes the nucleus management challenging. Using a low vacuum and high power in continuous mode, deep trench is made in the central anterior nucleus to penetrate the bulky nucleus more deeply with the phaco tip. And while trench is being done, use the other hand to support the nucleus using Sinskey hook to avoid the zonular descent by pushing the nucleus forward. Vertical chop using a long and sharp chopper tip is done so that it will best incise into the dense nuclear face without displacing it, and also helps in posterior plate separation. So the crack is achieved here using a multi-level chopping technique and a gentle lateral separation. The same is repeated by rotating the nucleus 180 degrees to separate the posterior plate. Total separation of fragments, deep plane phacoemulsification, and using chopper as a shield to protect fragments touching the endothelium. Incisions are the same is cracked, being made very minimal stromal edema. Coming to another case of vertical chop using a long ingot, and also helps in achieved here using a multi-level chopping technique and a gentle lateral separation. The same is repeated by rotating the nucleus 180 degrees to separate the posterior plate. Now each heminucleus is chopped into the smaller fragments. By using a multi-level chopping technique and a gentle lateral separation, avoiding stress on the zonules, and the number of fragments is directly proportional to the hardness of the cataract. The fragments are emulsified using a high vacuum and a burst mode. Total separation of fragments, deep plane phacoemulsification, and using chopper as a shield to protect fragments touching the endothelium are some of the strategies to prevent corneal endothelial damage. While removing the last fragment, replace the chopper with a Sensei hook and inject viscoelastic that resists the aspiration and prevent rampling of the posterior capsule. Residual incisions are then sealed and checked for wound leaks. And this is post-op day 1 picture with very minimal stromal edema. Corneal endothelial damage. Operation. The same is repeated by rotating the nucleus 180 degrees. And you could see the posterior plate is completely separated. Now each heminucleus is divided into the smaller fragments using a gentle lateral separation, avoiding stress on the zonules, and then emulsified. To conclude, these are some of the strategies I would like to share while dealing with hard cataracts. Good pre-op evaluation and liberal usage of viscoelastics is important. We need to be extra cautious to spend more time while doing these surgeries. Thank you.
Any post-op intraocular complications or something?
No, there were no
There were no complications. And any IOP fluctuation post-op?
No, there were
Nothing
no
like that.
complications.
Okay, thank you.
Thank you.
I would like to invite another presenter. This is Dr. Sneha Jan. It's stuck with my first Malugan.
Stuck with my first Malugan. There are many firsts in every surgeon's career. Here I am sharing my first experience with a Malugan ring. A 80-year male patient with not very hard cataract was posted for cataract surgery in right eye with mid-dilated pupil and history of tamsulosin intake and with shallow anterior chamber. Billowing of pupil was noticed with injection of adrenaline. So I knew this iris is not going to behave well. I stained the anterior capsule before injecting OVD. As the pupil did not dilate with OVD, I decided to go in with a Malugan ring. I could manage to get 2 out of 4 scrolls engaged while introducing the Malugan ring. And engaged the third scroll with the Sinski hook. Following which I proceeded with the last one. I completed the rexis taking care of the free edge so as not to let the tear extend to the periphery. I tried to manage the capsular tear part with the microrexis forceps and then started with the hemirexis on the left side with a cystitome. As the rexis was still not complete on the other side, I used a pair of micro scissors and then completed it with the microrexis forceps. After that, the usual steps of gentle hydrodissection and delineation, a gentle phacoemulsification, taking care not to cause much of AC fluctuation, and then cortical cleanup with the help of Simcoe cannula for safety reasons. After that, a single piece acrylic IOL was injected into the bag, and Malysian ring was removed and case was closed after viscoaspiration. At the end of 4 weeks, the patient had good post-operative vision. But I had learnt my lesson before doing my next Malysian ring. I could manage to get 3 scrolls engaged while introduction, and then injected OVD between the iris and the capsule before going for the last scroll with the help of Sinski hook. So at the end of the day, I learnt my lesson and learnt to use a Malysian ring properly. I was happy that I was able to handle the case properly and the patient had good vision, which is our main goal. Thank you.
Nice video, doctor. Just I want to know, have you done any pre-op workup for this patient? Have you started with some medication for pre-op something?
No, it was a routine case.
Because sometimes we can try atropine also in these type of cases in which we can think of this situation.
The patient was given cycloplegic,
Okay, okay.
cyclopentolate, but then it did
It's
not
not-
have any effect.
Okay, okay, okay. Thank you.
Thank you.
So I would like to ask the next presenter, Dr. Nikita Berry, on use of aqueous angiography to augment surgical outcome of MIGS. She is there, Dr. Nikita. Okay, we will move to another presenter. Dr. Sudesh Kumar Arya is here. So, sir will be presenting on pneumophacoseal, what is it and how to manage.
So this was a very interesting observation in this patient. This patient was no audio. This patient was having routine phacoemulsification planned. So it was case of high myopia with almost minus 10 diopter power. So during the surgery, there was a very interesting observation which have not been seen in the literature. So that I just wanted to share, very small observation. So while doing phacoemulsification, all the steps were routine, just like normal phaco. You can see all the incisions were made normal, and everything being done properly. So after doing stop and chop technique, you can see all the pieces, they came out. So we can see everything going well. And then after, at the time of this aspiration, when the epinucleus and the cortex was being aspirated, suddenly now you will observe something very interesting finding. So when the wounds are leaky, sometimes you may see some air may enter into the anterior chamber, then that is normal. And if you put aspiration cannula, that air can be taken out. But here now you can see something is popping up from here. Very big bubble coming from nowhere, not very clear on the table. And then I tried to aspirate, it was not coming, because it was actually not in the anterior chamber, it was behind the posterior capsule. So that was very interesting observation, because normally this air can come from the wound on the anterior capsule, but this was behind the posterior capsule. So I was very surprised from where this is coming. So I tried to remove it, it was not coming out because it was behind the posterior capsule. So then what I did, I just tried to push viscoelastic over in the bag, and because of that viscoelastic, the bubble was displaced on the lateral side, that is on the posterior part of the capsule and on the sideways. So once that was done, then I could easily aspirate this remaining part of the cortex. So you can see everything was removed nicely. So then when this was done, again this bubble was coming. It means that was still was not aspirated, and again it came out in front of this capsule, but again it was behind. So then again I had to put a lot of visco, and just I had to displace the capsular bag by stroking over the anterior capsule on the peripheral part. At this time I just tried to see whether any PC rent is there or some other thing, journal dialysis, so nothing was there. You can see the posterior capsule, anterior capsulotomy, everything is normal, no vites was there, everything was perfect. And then by manipulation of the instruments, the bubble was pushed on the lateral side, and then I implanted the IOL also. So you can see once the IOL implanted normally, so after that again just by pushing the iris downward, I could see that air bubble came out, and then after that there was no air bubble at the end of the surgery. So then I was just wondering from where this air came and what was it. So I then retrospectively I could thought, because it was a case with high myopia, so sometimes in the high myopia the granules, maybe there is a big gap among the granules. So while doing a procedure, the air entered through the granules behind the posterior capsule, and then while manipulating on the iris surface, it came out. So it was just a very interesting observation, just wanted to share. Yeah. So not reported in the literature, this type of thing.
Nice presentation, sir.
So basically one should not be concerned about this type of happening during the surgery, just one should wait and watch and try to remove it by just gentle maneuver over the iris, and it will come out. I think it is for the first time, and I have not seen in the literature also what is this exactly.
Yeah, it's quite a good observation, sir. So I think it's quite a not the usual thing. It's an unusual thing you have encountered with.
Because it was being recorded, so that's why I could just.
And could be because of the zonular discence or somewhere in the.
But there was no histotrauma, young patient 50, so nothing, no pseudoexfoliation, no other parameter which can suggest the journal dialysis or phacodonosis. That was not there. That's why it was interesting.
Okay. Nice presentation, sir.
Thank you.
Thank you, sir. I would like to invite another presenter, Dr. Sarat S., who would be presenting on post-traumatic corneal scar with cataract and RIOFB.
Morning everyone. Please. Excuse me, voice over is not coming. Sir, voice is not coming.
Video would be the location of the main incision. The phacoemulsification probe has to be visible or situation. So my first step from this video would This is a 64-year-old male patient with severe post-traumatic coronary scar with nuclear sclerosis grade 3 with multiple intraocular foreign bodies on posterior segment ultrasound scan. So this video demonstrates phacoemulsification in such a difficult situation. So my first step from this video would be the location of the main incision. The phacoemulsification probe has to be visible always during phacoemulsification, and hence in this case, since the nasal cornea is clear, I'm choosing a temple 2.2 incision. Stain the anterior capsule using trypan blue dye so that you can visualize the anterior capsule properly. Release all the posterior synechiae using a viscoelastic cannula. Since there is poor visibility, you can operate all these cases under retroillumination. Retroillumination will enhance the visualization. Next difficult step would be the anterior capsular rhexis. To begin with, you start the anterior capsular rhexis using a cystitome in a clear corneal area. You can tilt the globe to enhance the visualization. You can continue the capsular rhexis either using a ultra forceps or an ILM forceps. Since I can manage it through a side port, I'm using an ILM forceps. Here again, you may lose the anterior capsular rhexis under the corneal scar. So hence you will have to leave it just before the corneal scar, and you will have to surpass it without leaving it underneath, and then again grab it, grasp it, re-grasp, and continue the anterior capsular rhexis. Once the continuous curvilinear anterior capsular rhexis is done, you can do a gentle hydrodissection and delineation. The next step would be phacoemulsification. Here also I prefer to do a primary chop so that you can avoid zonular stress. We need to coat the endothelium. For that, we can use a soft shell technique. First, you inject a viscodispersive substance, and then you inject a viscocohesive substance. Monitor the accumulated dissipated energy throughout the procedure. You can re-inject the viscodispersive substance in between during phacoemulsification. Methyl cellulose can be injected onto the cornea to enhance the visualization. Now chop it into small pieces, rotate it, always bring the pieces during chopping towards an area where the cornea is clear. Once the chopping is done, you can take out pieces one by one and emulsify it, that too in an area where the cornea is clear. In this case, once I'm done with the phacoemulsification, I could see a vitreous foreign body. Next step is to remove the cortical matter. Here I'm trying to use a coaxial probe, but since there is an inferior corneal scar, I cannot see the cortical matter inferiorly. For that, I'm using a hybrid coaxial probe where the irrigation is being done with a coaxial probe and aspiration is done using a side port. The sleeve of the coaxial probe has to be advanced. A monofocal clear lens into the capsular bag injection. Once it is being injected into the capsular bag, you tuck one of the haptics underneath the anterior capsular rhexis and dial it, rotate it, and make sure that the other haptic is also underneath the anterior cap and suture the wound to prevent further iris prolapse. Also, since these are scarred corneas, at the end of the surgery, hydration will be inadequate and the wound apposition will be less, and hence always suture the main incision in such cases where there is a scar at the wound site. And removing the viscoelastic substance from the anterior chamber, while removing the viscoelastic substance, I could encounter another foreign body which was stuck in the angle. I was trying to feed it in the IA probe. It is not coming in. So I've decided to inject a little more viscoelastic into the anterior chamber and take it out with an ILM forceps. Once it is taken out, I'm again removing the viscoelastic substance.
So you have started late, no? This is just a 4-minute video.
Okay, so what was the foreign body you have encountered with? Have you just checked?
Sir, would you allow me to present completely because I've started late only. It's a 4-minute video. Many
you just
people
allow
have
it?
exceeded the time. He's not allowing me to present.
Just allow for 2 minutes.
It is a 4-minute video completely. I've not exceeded the time. Please. It's a 4-minute video. I've not edited more than 4 minutes. Please allow. I've seen many people
please allow
presenting
him,
more
please
than
allow
4
him.
minutes and you are stopping it, please.
Can you extend the time for 1 more minute?
And take it out with an ILM forceps. Once it is taken out, I'm again removing the viscoelastic substance from the anterior chamber using a bimanual irrigation aspiration cannula. Slowly, you remove all the viscoelastic substance from the anterior chamber. Air is being injected and all the wounds are hydrated. On post-op T1, the patient got an uncorrected visual acuity of 6/18 and the patient was so happy. Since the vitreous foreign body was inert, we have not intervened. Thank you.
Sorry, sir. Sorry for the trouble.
Yeah, no problem. So what was that foreign body you encountered with?
So it was a glass foreign body which was missed on the ultrasound which showed that I couldn't get the ultrasound images. What the report was written was a moderate amplitude spikes we thought would be some resolving vitreous hemorrhage that was missed on the ultrasound. So that was a glass foreign body which we could visualize, as well as on examination also we could see.
Okay, thank you.
Thank you, sir.
I would like to invite the next presenter, Dr. Pratik Tiwari. He will be presenting on Tenon's patch graft in managing sterile corneal perforation.
Excuse me, is it visible?
Can you start the presentation?
Yeah. Yeah, so good afternoon, everyone. So here I'm presenting one interesting case which I encountered. This is a case of 50-year-old female. She was suffering from rheumatoid arthritis for last few years, and she was having severe dry eyes. And there was a sterile corneal perforation, which you can notice. There is iris incarceration, and to close the perforation in such cases is very difficult. So as you can notice here, there is aqueous deficiency dry eye, which is clearly visible. So what options did I have? So first is the Tenon patch graft, the second is the AMG, and the third is the corneal patch graft. So I chose Tenon patch graft in this case. I will explain the reasons later. So this is again the positives of AMG graft. So I'll skip in the interest of the time. Yeah, so Tenon patch graft, the major advantage of Tenon patch graft is that it allows the epithelium to migrate over its surface, and the fibroblasts within Tenon's layer, they help in wound healing. So as the wound heals, the tissue gets integrated within the scar, and it forms in the area of the perforation. It addresses the volume deficit, and there is no immune response that is evoked. So the challenge is that the tenon is not impervious to aqueous, so there can be post-op leak. So it can require support of drape or amniotic membrane. So, but it can be pinned against the perforation site with the help of cross overlay sutures. So I'm going to describe the video here. Sorry. Yeah. So this is the case. First of all, you have to the tenon patch graft has to be started in the infero nasal area. Subconjunctival injection of lignocaine and erdelin has to be given, and then you just have to excise the conjunctiva over the tenon, and take a hefty bite of tenon. The tenon is separated and excised. The tenon is then placed over the area, the site of the perforation. So because I could manage a very small bite of tenon, so I explored again. So here I could manage a good amount of tenon. So one important tip here is to use pre-op brimonidine, so it reduces bleeding, but I haven't used here because it wasn't available at that time. Then the perforation site is deepithelized, and glue is to both the thick and thin component of fibrin glue are used, and you have to just place the tenon, drag the tenon and place it on the perforation site, and take cross overlay sutures over the. So post-operative course is okay. Time is up. Excuse me. Is time is up? Time is there or time is up? Okay. Thank you.
Okay, nice presentation. Thank you for your presentation. I would like to. I don't have any questions for regarding this. As we have to expedite the time, we don't have that much time. Thank you for the presentation.
Thank you.
Yeah. So next presentation will be with Dr. Shalu Chauhan. She will be presenting on unintended encounters of dexamethasone implantation into the lens.
As we all know, dexamethasone, Ozurdex is a dexamethasone implant which is given intravitreally to treat diabetic macular edema. But in some cases, very rarely this happens that when the surgeon is a beginner or the patient is not very cooperative, the injection is not given intravitreally properly. It might get misplaced somewhere else. So this is a case where instead of vitreous, the implant was injected inside the lens. So I will walk you through a surgical representation of how we dealt with this patient. Site of entry from where the injection was given and the implant has breached the PC and entered the lens. So since the surgery was performed 15 to 20 days after the injection, the capsule was fibrosed and there was no vitreous loss or vitreous leak. So
Nice video. It's just a rare complication of dexamethasone implant, actually. Yeah. So you manage well. That's any decentration of IOL
no,
after?
sir, nothing of that.
Nothing.
The
Any?
patient had 6/9 vision the next day.
Okay. And what about the pre-op any IOP fluctuation in the pre-op period or something?
No, sir. Basically, this patient presented to us for a regular checkup. This is when we noticed that there was some foreign body inside the lens.
Okay.
And then we went with anterior segment OCT to take a look at the posterior capsule also. So at that time, it was fibrous and it was intact. So
Okay.
that is how we proceeded. We were planning on removing the implant if we were able to, but then it was not. It was deeply rooted, so we had to go ahead with the cataract surgery as well.
Okay.
So
Okay.
it went.
Yeah. Thank you. A nice presentation.
Thank you.
So I would like to invite the next presenter, Dr. Rishi. He will be presenting on split anterior capsule double access.
video is not there? हाँ? मैं उसमें
I think that will take time, so I will be moving to the next presenter, Dr. Manish Mahendra, who will be presenting on pupilloplasty and iodialysis repair modified technique.
This video will demonstrate modified iris tear repair techniques. This is a case of traumatic cataract where pupilloplasty is being performed after cataract surgery. In the iris is taken close to the pupillary border. A 26 gauge needle is now passed through the limbus on the other end, and a peripheral bite of the iris tissue is taken in the similar fashion close to the pupillary border. The 9-0-proline suture is now dogged in the lumen of the 26 gauge needle in a railroad manner, and the needle along with the proline suture is gently pulled and withdrawn. The inside suture loop is now pulled out using a Sinskey hook or a McPherson forceps. Once the loop is withdrawn, now we have a suture end and a loop. We will now pass this suture end through the loop and give 4 throws. Watch carefully here. So once you have given 4 throws, you can now pull the suture end on both the sides. Finally, the suture ends are cut with a vitreoretinal scissor, and thus a single pass 4-through pupilloplasty performed. So as to get a wider view. Rhexis was performed using a cystitome. Echo-aspiration was performed. Peritomy is performed and scleral tunnel made 2 mm from the limbus parallel to the damaged iris tissue portion. Externalized. Similarly, the other end of the double arm needle is passed through the peripheral iris and also externalized.
So both these sutures are then pulled and they are tied, and then the knot is buried.
Both double-armed sutures are pulled and tied, and the knots are buried in the scleral tunnel. The damaged iris tissue is thus repaired. Modified sewing machine technique.
This is another technique.
In this case of traumatic mature iridodialysis, cataract damaged iris tissue portion. Scleral tunnel is made 2 mm from the limbus parallel to the damaged iris tissue portion. 9-0-proline suture is dogged and passed through the 26 gauge needle
This needle is now dogged in the 26
and then pulled from the opposite side, leaving a small tag of the suture in front of the needle tip.
left in front of the needle.
The 26 gauge needle with the proline suture is passed through the peripheral iris and externalized through the scleral tunnel. Suture is pulled out through the needle and held on. The needle is then gently withdrawn and a second bite in the peripheral tissue is taken adjacent to the first one in the similar fashion and suture
You
is
can see you have this
pulled
now.
to form a
And
loop.
when
Once three loops are
the
formed,
needle comes out,
the suture
this needle,
is gently withdrawn from the 26 gauge needle.
so finally this needle is now full, and now you can see this needle, and now I will pass this
It is
needle
then
through the loops that are created
passed through the
and pull
loops.
the two ends of the suture.
The ends are then tied and the
And
knot
there you see the pupil
buried
gets
in the spiral
rounded up.
tunnel. Thus the pupil gets round
You can
and
bury
the arteriodylysis gets
the knot,
repaired.
and then you can implant the lens.
This is
So
followed by
that's
implantation
how you can
of the
repair
lens,
these arteriodylysis cases.
and the conjunctiva is covered and cauterized. This is the post-op day 1. Thank you for watching the video.
Thank you.
Nicely managed. Paid most of them these type of cases.
No, initially, like you can, if you see here, the pupil is slightly mid dilated. So sometimes these people they complain of glare and all, but then over a period of time they get over it.
Okay. Thank you.
Thank you.
So moving on, next presenter. Yeah.
Here I'm showing a case of 80-year-old female, and she presented to our OPD with a grade 2 cataract, and there was the pre-op was no special findings were noted. She was a homemaker by profession and no systemic illness. So on after inserting of dye, the usual process were followed, but as I proceed with my rexis, I can see that there is division. The capsule is divided into the anterior and the posterior portion. Here you can see that the anterior most capsule part is running little radially, and the distal one is behind it. So there are two options, and this I noted during the rexis formation, and I continued with the outer one. As I was continuing and I proceeded till the end, then the behind capsule, the split capsule was noted, which was not complete. So the risk with this kind of splitting is that we may proceed with the phacoemulsification, and there are chances that the rexis may run out behind the capsule. So you have to lower the parameters, and you have to take care that you can lower the bottle height also, and take care that no tag is there. So I tried to remove the tag from the behind the splitter part. So it is a very rare case of true exfoliation where you can see that the anterior capsule has divided. The theory is that the lens equatorial cells, they stop doing mitotic activity, and then when they resume, then there is an aberrant regeneration which causes vacuoles in between the capsule, which coalesce and form a split. This in some videos and cases reported that the surgeon proceeded with the anterior most of the capsule rexis and proceeded with the phaco. So there can be a chance of nucleus drop. Thank you.
Nice video, doctor. Thank you for the presentation. I will be moving to the next presenter, Dr. Shruti. She will be presenting on Jones procedure 2.0.
Entropion is the inward turning of the eyelid. An ophthalmic plastic surgeon's armamentarium for entropion correction includes several procedures like Quickert sutures, Weiss procedure, Quickert procedure, and the classical Jones procedure. Jones procedure was first described in 1972, in which the lower lid retractors were pulled ahead and plicated to the tarsus through a subciliary incision and brought out through the skin. But the weakening of the capsulopalpebral fascia due to aging limits the vertical traction provided by it, and hence the result given by Jones procedure. Therefore, a modification for the Jones procedure was sought. Our modification, we cut and reattach the lower lid retractors to the tarsus, thereby restoring the retractors to their normal anatomical position, instead of only bringing a part of the retractors forward. This procedure, in combination with lateral lid tightening procedures, can be employed to correct horizontal lid laxity. To diagnose horizontal from the
Directly
globe and
skip to the
see
surgical
medial
video
canthus lateral canthus.
for the interest of
Right,
time.
by placing this override by presenting a clinical case of a 58-year-old female with complaints of left eye irritation and inward turning of the left lower lid since 1 year. Patient also has a history of right eye lower lid entropion correction done 5 years back. Examination reveals preseptal override and lash globe contact necessitating surgical correction for this patient. Here is a video showing the surgical steps of modified Jones procedure. A lower lid traction suture is taken with 4-0 silk to secure the lower lid in an approachable position. Skin incision is taken using 15 number blade 2 mm below the lid margin. Sharp dissection of the orbicularis is done up to the tarsal plate. The lower lid retractors are identified and confirmed by asking the patient to look up and down. The inferior surface of the retractors is dissected and a double-armed absorbable suture is passed centrally through the edge of the retractors. The retractors are then secured onto the anterior surface of the tarsal plate in a horizontal mattress fashion. Similar sutures are taken laterally and medially to reattach the retractors throughout the tarsal plate. Skin closure is done using an absorbable suture in a continuous fashion. This is the preoperative photograph of the patient, and this is 1 week postoperative. Don't be misled by the frown lines. The patient was very happy with the results.
Thank you.
Thank you for the nice presentation. So this will be the end of this session. I think all the speakers have spoken. So that will be the end of this session. Thank you.